Bun găsit la emisiunea Știință și Cunoaștere. În minutele următoare vom continua partea a doua al celui mai șocant, tulburător și îngrijorător interviu din câte am realizat vreodată. Veți afla noutăți din povestea interzisă a statinelor și colesterolului și vom continua să dezvăluim cele mai cutremurătoare afaceri din istorie, în baza căreia mulți dintre noi, inclusiv eu, am fost înșelați, am fost puși sub medicație continuă, iar corporațiile farmaceutice prosperă de pe urma noastră. Trebuie să precizez că sub nicio formă această emisiune nu poate fi considerată un înlocuitor al consultului medical de specialitate, iar opiniile prezentate aparțin exclusiv invitatului și nu sunt opiniile mele sau ale televiziunii române. Voi continua prezentarea datelor biografice ale invitatului emisiunii, care sunt absolut impresionante, uimitoare, dovedind o activitate susținută, încununată de succese, aprecieri, diplome, recunoașteri internaționale, articole și cărți publicate. L-am cunoscut pe Dr Paul Rosch cu ocazia vizionării unui film documentar numit Naţia Statinelor, Partea 1 și 2. Fiind vocea principală alături de încă 12 invitați de mare notorietate, am căutat o adresă de contact pentru a-i propune un interviu de lungă durată. Ceea ce am aflat din film a fost terifiant, dar ceea ce am aflat din interviul înregistrat prin Skype a fost cu mult mai tulburător. Având un subiect atât de delicat, a trebuit să fiu extrem de atent la alegerea invitatului, așa că am verificat cu maximă severitate datele biografice ale profesorului Paul Rosch. În continuarea celor prezentate data trecută, mai adaug următoarele date biografice. Dr Paul Rosch este membru al Consiliului pentru Cardiologie Geriatrică, certificat cu înalte competențe și membru al Academiei Mondiale de Artă și Științe și al Societății Regale de Medicină. El a fost ales în unanimitate în anul 1999 ca membru deplin al prestigioasei Academii de Științe Medicale din Rusia, fiind unul dintre cei 6 străini care au primit această onoare în ultimii 20 de ani. Dr. Rosch este consultant senior în medicină internă și medic emerit onorific la Spitalul St. John's Riverside din Yonkers, New York și este autorul unui studiu numit Evaluarea compensării muncitorilor subspecializați în cardiologie, endocrinologie și boli metabolice. Dr. Rosch a fost editorul șef al revistei Stress Medicine din Anglia, a fost editor asociat al Jurnalului Internațional de Sănătate Mentală de Urgență și a Jurnalului Internațional de Stress Management. A colaborat în comitetul editorial al altor publicații, inclusiv Jurnalul Stresului Uman, Jurnalul Internațional de Psihosomatică, recenzii și rapoarte cardiovasculare, Terapia Comprehensivă, Jurnalul de Comportament Uman, Sănătatea informează și informații esențiale privind asistența medicală alternativă. El a organizat și a prezidat Congresul Internațional Anual de Stres începând din 1988, prezentând lucrări de ultimă generație privind toate aspectele stresului, precum și cercetări de ultimă oră în domenii relevante ale bioelectromagnetismului și ale medicinei de frontieră. Dr. Rosch este autorul secțiunii Wellsprings of Health din Creative Living și este redactor șef al Sănătății și Stresului, un buletin lunar al Institutului American de Stres. El a scris intensiv în ultimele 6 decenii cu privire la rolul stresului în sănătate și boli, în special în ceea ce privește bolile cardiovasculare și cancerul, precum și probleme asociate stresului de la locurile de muncă. În ultimii ani și-a concentrat atenția asupra efectelor psihofiziologice a energiilor insesizabile, în special cu privire la utilizarea clinică a aparatelor de magnetoterapie. El este coautor al Ghidului Medicilor pentru ameliorarea stresului spontan, al magnetoterapiei, detensionare, cure de slăbire și editor al revistei pentru medicină bioelectromagnetică. El a contribuit la promovarea medicinei bioelectromagnetice și a scris o carte de 50 de capitole publicată în anul 2015, precum și cartea care a șocat o lume întreagă numită Grăsimile și colesterolul nu provoacă infarct miocardic, iar statinele nu sunt soluția, publicată în anul 2016. Paul Rosch a apărut la numeroase programe de televiziune internaționale, inclusiv Nova, CBS, NBC, PBS, BBC și CBC. Interviurile și comentariile sale au fost publicate în reviste medicale majore, cum ar fi Revista de Medicină New England, Analele de Medicină Internă, Jurnalul Asociației Medicale Americane, Jurnalul Medical Britanic și renumita revistă The Lancet. El a fost intervievat și citat pe larg în Times, Fortune Newsweek, The Reader's Digest, The Wall Street Journal, New York Times, USA Today, The Washington Post, The London Times și numeroase alte publicații din țară și străinătate. A fost înființat un Institut Internațional de Medicină a Stresului în onoarea sa în Mexic, Instituto Internacional de Medicine del Tensión, Dr Paul Rosch. Citind toate acestea, eram năucit de formidabilele realizări ale domniei sale, gândindu-mă la șansele de a fi acceptat ca jurnalist ce dorește un interviu cu o personalitate de o asemenea notorietate. Și nu a fost deloc ușor, a trebuit să îndeplinesc multe criterii, să concep ilustrații cât mai adecvate și spre final am primit un mesaj de la profesorul Rosch în care îmi scria: ai făcut o treabă fantastică, you did a fantastic job on this. Rămâne de văzut cum va fi receptată aceasta și de către dumneavoastră, vizionând în continuare partea a doua a acestui interviu cutremurător, în care vom continua cu programele guvernamentale pentru nutriție ale Senatului SUA, cum s-a ajuns la restricționarea neștiințifică a grăsimilor saturate. Vom vorbi despre directivele alimentare pentru americani, care se observă a fi aplicate și în România. Vom vorbi despre siropul de porumb cu conținut ridicat de fructoză și multe altele. Credeați că știți totul despre dietă și sănătate? Mai gândiți-vă în timp ce vedeți partea a doua.
So, why does this persist? Well, the U.S. Senate Select Committee on Nutrition and Human Needs, chaired by Senator George McGovern, was established in 1968 to study the problem of malnutrition. It instituted a series of federal food assistance programs that appeared to be successful. But in 1974, McGovern expanded the committee's scope to include national nutrition policy, and the focus shifted from malnutrition to overeating, especially fats. Their 1977 report, Dietary Goals for the United States, was based on the beliefs that eliminating fat would lower cholesterol and reverse the rising incidence of heart disease.
So not only the conclusion of that report was not based on real data, but it was rather just a belief.
It was strongly influenced by the food industry and was written by Nick Motern, a former labor reporter for the Providence Journal, with no experience about writing nutrition or health. He relied heavily on Mark Hedsted, professor of nutrition at Harvard Medical School, who maintained that saturated fats elevated harmful cholesterol levels and should be replaced by monounsaturated and polyunsaturated fats that could have beneficial effects. These views were shared and endorsed by McGovern, who, along with his wife, had gone through Nathan Pritikin's program, which featured a low-calorie, low-protein, high-carbohydrate diet that severely restricted fat.
But this is amazing. I'm not sure how our viewers will react to all this, but it is a shock, because here in Romania we never read or hear the real history of cholesterol myth and the covert truth behind statins production. No wonder that our medical specialists won't speak freely on my TV program, because they could lose their jobs. This is incredible. Please, let's go back to raw vegan people, because here we also encounter a problem.
Maturin was a strict vegan who believed saturated fat was as dangerous as cigarettes. He urged everyone to cut total fat intake to less than 30% of total calories, limit saturated fat to 10%, and increase carbohydrates to 55 to 60%. No studies were cited to support this recommendation. A similar diet was proposed in the UK in 1983 that was also based on Key's 7-country study, although this merely indicated that coronary heart disease tended to be related to serum cholesterol values, and as these in turn tended to be related to the proportion of calories provided by saturated fats in the diet. Zoe Harcum's recent and very thorough investigation of all the pertinent clinical trials and studies that were available prior to 1983 concluded that a low or saturated fat diet should never have been introduced in either the US or the UK.
I never supported the idea of raw veganism, not even 100% veganism. I am partially a vegetarian, but from time to time I'm eating animal protein food and fats, and I'm feeling excellent. I have about 300 milligrams per deciliter cholesterol level, and at an age of 54 I am also feeling very good.
Matter's recommendations were also vigorously criticized by prominent experts here and in the UK, and would likely have been discarded when the government committee disbanded after his report was released, were it not for the USDA. In July 1977, Carol Foreman, a powerful consumer activist, was appointed Assistant Secretary of Agriculture. Her assignment was to make the McGovern Committee recommendations official U.S. policy and to increase the USDA's influence and participation in making all future dietary decisions. Because of all the negative publicity, she recognized this would require backing from respected scientists and organizations. The best and most appropriate resource would have been the National Academy of Sciences, which determines the recommended dietary allowances of calories and nutrients. However, Philip Handler, their president, who was an expert on metabolism, told Foreman that Matter's report was nonsense. Frustrated, she consulted McGovern's staff. They suggested hiring Harvard's Hegstead, who was then appointed in 1978 as USDA Administrator of Human Nutrition. Although there was no scientific support for Hegstead to find, the American Society of Clinical Nutrition had just issued 6 recommendations that included avoiding excess sugar, salt, alcohol, and total calories, as well as in cholesterol and fat, but did not provide any percentages for the latter. These recommendations were included in the 1979 Healthy People, the Surgeon General's report on health promotion and disease prevention. And they specified that the evidence for fat and saturated fat came from animal studies, but did not list any references.
Please tell us, what are the dietary guidelines for Americans, when they had been developed, and what are their purpose?
In 1980, the United States Department of Agriculture and the Department of Health and Human Services issued their first joint dietary guidelines for Americans, which recommended reducing saturated fat to less than 10% of total calories. These guidelines are revised every 5 years, but despite mounting evidence of the dangers of restricting fat, few changes have been made. The 1980 USDA guidelines urged Americans to avoid fat, especially saturated fat, resulting in a high carbohydrate diet and a plethora of low-fat food. Fat provides flavor, and to improve their taste, sugar and high fructose corn syrup, HFCS, had to be added to the food. The above graph shows a steady increase in obesity from 1980 to 2006. More recent data reveals that by 2014, childhood, age 2 to 9, obesity rates tripled. Rates of obese 6 to 11 years old more than doubled, from 7% to 17.5%, and rates of obese teens aged 12 to 19 quadrupled, from 5% to 20.5%. As of 2016, nearly 38% of the U.S. population was obese, compared to only 14% in the 1970s. The graph above and subsequent rises also mirror the increased rates of type 2 diabetes and high fructose corn syrup consumption, which has been linked to numerous serious diseases.
A lot of high fructose corn syrup and juices are manufactured and sold in Romania also. Let's go back a little to John Goffman. In the introductory part of our discussion, you said that he demonstrated that the existence of LDL and HDL. Did he continue the studies or not?
John Goffman, who was originally responsible for the notion of bad and good cholesterol, and is frequently cited as a proponent of the cholesterol theory, was well aware of these dangers and wrote in 1958, "Total cholesterol is a false and highly dangerous guide to the effect of diet on heart disease. Neglect of the carbohydrate factor can lead to serious consequences."
Well, that's a surprise.
In 1981, Hegsted returned to Harvard to do research sponsored by Frito-Lay on the benefits of substituting Olestra cooking oil for fat. Carol Foreman also left the FDA to become president and co-founder of a powerful public relations and lobbying company whose clients included Philip Morris, Monsanto, maker of genetically engineered corn and bovine growth hormone, Procter & Gamble, maker of the imitation research fat Olestra, and other huge food and drug companies. Frito-Lay was subsequently sued for labeling its GMO content as natural, and to avoid an additional lawsuit, agreed to emphasize on all labeling and advertisements that their low-calorie chips contained Olestra. Olestra is banned in Europe, Canada, and Australia because it blocks the absorption of fat-soluble vitamins and can cause severe abdominal cramps. The revolving door between industry executives or lobbyists and federal regulatory agencies is not unusual, particularly with respect to the FDA and drug and food companies. The graph above shows 16 examples for Monsanto alone and helps to explain why official recommendations are often designed to increase profits rather than improve health or prevent disease. This is aided and abetted by support from respected organizations that receive lavish funding from vested interests. As Dr. Marcia Angel wrote in her 2004 book, The Truth About Drug Companies, How They Deceive Us and What to Do About It, this industry uses its wealth and power to co-opt every institution that might stand in its way, including the U.S. Congress, the Food and Drug Administration, academic medical centers, and the medical profession itself. It is simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as editor of the New England Journal of Medicine. Things have gotten worse rather than better since then, but drug companies are not the only offenders. Because of the low-fat fetish, food manufacturers eliminated or reduced fat in their products. However, this detracted from their taste, so large amounts of high fructose corn syrup, HFCS, are added to make them more appealing, especially as sweeteners for soft drinks.
Please tell us about the danger of fructose and high fructose corn syrup.
As you can see from the above, Fructose and high fructose corn syrup contribute to a variety of diseases, including weight gain, cancer, fatty liver disease, increased cholesterol levels, diabetes, high blood pressure, heart disease, and other problems listed. Food and beverage companies spend $1.8 billion each year marketing HFCS products to children as young as 2 years old. Their advertising claims that medical and nutrition experts have determined that it's no different than regular sugar. Attempts to call it corn sugar were rejected by the FDA. HFCS has become the leading source of calories in the U.S. because it is hidden in so many low-fat foods and enhanced water drinks. Even most infant formulas contain the sugar equivalent of a 12-ounce can of.
So enhanced water drinks, that's an interesting commercial invention. So we are no longer using sugars but corn syrup, and thus the new juices are enhanced.
Add to that breads and baked goods, breakfast cereals, salad dressings, chocolate, nutrition bars, and even seemingly healthy foods like Dannon and Yoplait fruit yogurts. The reason for its popularity is that HFCS prolongs shelf life by preserving flavor and freshness longer. It's cheaper than sugar, easier to transport, and can be used in so many different foods and beverages. Corn is the largest crop in the United States, and the government pays farmers more than $77 billion a year to produce corn and over $24 billion for soybeans that can be used to make foods. However, close to 90% of both these crops are genetically modified and can't be eaten until high fructose corn syrup is added to significantly improve their taste. As noted previously, fructose and HFCS have been found to have serious adverse effects, including the development of metabolic syndrome, hypertension, increased abdominal fat, type 2 diabetes, elevated triglycerides, and increased risk of coronary heart disease. Nevertheless, low-fat foods are still advertised as being heart healthy.
But this is only the visible part of the iceberg. All these myths began to connect each other and generated new myths. Please tell us about fats and obesity.
Another popular myth or misconception is that high-fat diets cause weight gain and obesity because you're consuming more calories per gram of food. The fact is that carbohydrates are more apt to cause weight gain because they increase insulin levels. This is particularly true for foods with a high glycemic index or load, such as sweetened soft drinks, fruit juices, pastries, breakfast cereals, and snacks. Insulin is an important regulator of energy and causes liver and other cells to synthesize fat from glucose and store it as visceral fat. Insulin resistance is a disorder in which cells do not respond to insulin, which leads to dyslipidemia, obesity, heart disease, and other manifestations of metabolic syndromes. Numerous studies show that the best way to prevent this and to lose weight is not to restrict fat, but rather carbohydrates. In one of these, women eating a low-carbohydrate, high-fat diet until they felt satiated lost more than twice as much as controls eating a calorie-restricted, low-fat diet.
If high cholesterol doesn't cause atherosclerosis or heart attacks, then how do you explain the ability of statins to prevent future coronary events in patients who have had a heart attack? And how do you explain what appear to be pleiotropic benefits in cancer, Alzheimer's, infections, and numerous other diseases?
Well, the cholesterol hypothesis is based on the assumption that myocardial infarctions are due to the buildup of atherosclerosis inside a coronary artery that progressively slows the flow of blood and can result in complete blockage. As previously demonstrated, there is increasing evidence that cholesterol and fatty foods do not cause heart attacks or coronary atherosclerosis. Although statins may benefit patients who have had a myocardial infarction, this is not due to lowering cholesterol or LDL, but rather anti-inflammatory, anticoagulant, and other non-lipid pleiotropic effects. Statins have also been promoted to treat or prevent Alzheimer's, colon cancer, osteoporosis, kidney damage in diabetics, macular degeneration, autoimmune diseases like rheumatoid arthritis, inflammatory bowel disease, as well as to decrease rejection rates in organ transplants. There's no evidence of elevated LDL in these disorders, nor any reason to suspect that long-term statin therapy would be either beneficial or safe. It's important to reemphasize that association never proves causation. Most patients receive statins because of an elevated cholesterol that may have been present for decades and likely protected them from infections, Alzheimer's, and other diseases.
Please tell us about the profits regarding statins selling and how did the companies reach the conclusion that statins are good for our health?
Statins have been the most profitable and best-selling prescription drugs ever, but fierce competition has now forced drug companies to find ways to prove their product is superior or safer, which is difficult to do since all statins lower LDL and pose similar health hazards depending on their dosage. Lipitor, avorstatin, which was approved in 1996, brought in over $124 billion until its patent expired in 2011, and Atarbast is now by far the top-selling generic drug. Crestor, rosuvastatin, was approved in 2003 and was quirkily nicknamed Gorillastatin or Superstatin, since AstraZeneca spent over $1 billion on advertising and promoting it the first year. It has brought in $3.4 billion since then, and a generic version became available in 2016. Pleiotropy refers to a drug's actions other than those for which the agent was specifically developed. All drugs have pleiotropic effects, which are usually manifested as adverse side effects. For example, aspirin was developed to reduce pain and fever, but it also causes gastrointestinal bleeding, as well as hives or other allergic reactions in sensitive individuals. On the good side, aspirin helps to prevent heart attacks because of its powerful anti-inflammatory and anti-clotting properties. Only a very small dosage is required to provide cardioprotection, and the risk of GI bleeding can be lowered by taking buffered or enteric-coated aspirin.
Yes, I agree with you, but what happened in patients with coronary heart disease? They need treatment.
Patients with coronary heart disease tend to have increased fatty deposits, rich in cholesterol on the inner surface of their coronary arteries that impairs the flow of blood. This favors the formation of clots that can completely block blood flow, which results in a myocardial infarction. But as shown above, the studies now show that 75% of heart attacks are due to blockage of the coronary arteries as a result of small, soft plaques that break off due to inflammation, rather than large atherosclerotic plaques that block coronary blood flow. It is now believed that statins provide benefits to patients who have had a heart attack or have significant cardiac disease because of non-lipid anti-inflammatory effects that stabilize vulnerable plaque and reduce clot formation. If so, aspirin, which is much less expensive and probably safer, might be equally or more effective, especially for long-term or perpetual therapy. And it does not lower cholesterol or LDL.
The belief that the benefits of statins appear to be due to their anti-inflammatory effects was supported by the Jupiter study, which showed that lowering protein C reactive with Crestor was superior to lowering LDL in predicting future coronary events. The asteroid study showed Crestor reduced atherosclerosis in coronary arteries. But can you explain why you and others have criticized both studies and how inflammation causes atherosclerosis?
Yes, asteroid, which is an acronym for a study to evaluate the effect of rosuvastatin on intravascular ultrasound-derived coronary atheroma burden, allegedly showed that 40 milligrams of Crestor daily for 2 years reduced plaque volume by 40%, which increased blood flow as illustrated by the intravascular ultrasound study shown above. This was the maximal available dose of Crestor, since an 80 milligram tablet was not approved because of the higher incidence of myopathy and fatal rhabdomyolysis than was originally reported, and lack of proof that it was more effective than 40 milligrams. In actuality, it was the cross-sectional areas of atheroma that were compared before and after treatment, since it was presumed that the area of the lumen would increase proportionally. What was not mentioned in either the press release or the article was that the lumen area and blood flow actually decreased due to thickening of the arterial wall. In addition to a decreased blood flow, a smaller lumen and stiffer arterial wall would tend to increase blood pressure, an effect that was also not addressed in the published report. Nor was the high dropout rate of 25% due mostly to adverse side effects ever explained.
Okay, so this study was also a straw fire like many others, but there is one which really got my attention, and I also discussed that in my previous episodes. Please tell us about the amazing, infamous, and deceptive Jupiter study.
Jupiter revolutionized statin therapy. It's an acronym for justification for the use of statins in primary prevention and intervention trial evaluating rosuvastatin. It enrolled 17,800 healthy men and women with a normal or low LDL and elevated high sensitivity C-reactive protein test that is supposed to measure inflammation. It was a randomized, double-blind, placebo-controlled study in which half were given 20 milligrams of Crestor daily and half a placebo. The endpoints were various coronary events, and the purpose of the study was to determine the efficacy of Crestor in preventing them in people with no history of heart disease. The study was to have lasted 4 years, but was halted in less than 2 by an independent data and safety monitoring board because of, quote, unequivocal evidence of a reduction in cardiovascular morbidity and mortality in patients treated with rosuvastatin compared to placebo. Those on Crestor reduced their risk of coronary events and disease by 44% more than controls who received a placebo. LDL plunged 50% to an average of 55 milligrams per deciliter, and high sensitivity CRP fell 37%, but there is no correlation between the C-reactive protein drop, and the degree of LDL level. Nor was there any evidence that the reduction in coronary events was related to either LDL levels or how much they were lowered. However, it was associated with the reduction in the high-sensitivity CRP. This was groundbreaking because it appeared to demonstrate for the third time that a statin could prevent coronary events and deaths in healthy people, as well as the fact that this was not due to lowering LDL, but rather reducing CRP and presumably inflammation.
Well, that's a shock, but that was not what the media at that time told us. What happened next?
This was a stunning blow to proponents of the lipid hypothesis who had convinced government authorities, American Heart Association, American College of Cardiology, numerous other prestigious organizations and experts, that the goal of statin therapy was to lower LDL as much as possible. A subsequent task force confirmed there was no scientific support for this, nor had it proved effective. They recommended that statins be given on a 10-year risk of coronary disease of 10% or more based on age and other arbitrary risk factors. This meant that 13 million healthy Americans would now be eligible statins, including almost half of those over 40 and 87% of men and 54% of women age 60 or older.
Please tell us about risk factors, relative risk, absolute risk, and number needed to treat. What does these terms exactly means?
As shown in this diagram, the Jupiter study showed a 44% risk of coronary events in healthy people with no heart disease, but an elevated high-sensitive CRP. The trial, which should have lasted 4 years, was stopped in 2. Critics claim this is because the two curves were now converging. Based on the Jupiter study, the FDA approved Crestor in 2010, quote, to reduce the risk of stroke, myocardial infarction, and arterial revascularization procedures in individuals with no evidence of coronary heart disease, but with an increase of this risk of this based on age, high sensitivity C-reactive protein, and the presence of at least one additional risk factor, such as hypertension or low HDL, smoking, or family history of heart disease.
Okay, so this established HSCRP as a risk factor, but what does this really mean?
It implies causation. For example, your doctor tells you there's a new statin drug, no side effects. One study showed that if you take it every day for the next 5 years, your risk of heart attack will be reduced by 34%. But this is relative risk. What you are not told is that after 5 years, 2.7% patients taking this drug had a heart attack, compared to 4.1% taking a placebo, which is an absolute risk reduction of only 1.4%. Nor are you told the NNT, number needed to treat. 71 people would have to take this daily for 5 years to prevent one heart attack. Getting back to Jupiter, its risk reduction of 44% implies that taking Crestor for 2 years would reduce your risk of coronary events and death by almost half. But this was relative risk reduction. The actual risk reduction was only 1.2%, and the NNT was 95, so that only 1 in 95 would benefit, and it is not known if it would be you. A risk factor only indicates there is an association, and this does not mean causation. since most are merely risk markers. There are over 300 such risk factors or markers for heart attacks, including a deep earlobe crease, pot belly, or premature vertex baldness. However, removing these with plastic surgery, liposuction, or a hair transplant will not lessen the likelihood of a heart attack. The 10-year Mr. Fit study in 13,000 middle-aged men, which reduced the three leading Framingham risk factors, smoking, cholesterol, and hypertension, found no decrease in cardiac deaths, but there was an increase in total mortality due to cancer, suicide, and stroke.
That was an amazing, in-depth presentation of Jupiter study. Thank you very much. Please let's talk about inflammation and atherosclerosis and also put this into a historical presentation.
Rudolf Virchow, who first noted the presence of cholesterol and atheroma in 1856, described atherosclerotic plaque as endoarteritis chronica deformans nodosa. The suffix itis emphasized that it resulted from an inflammatory process that had injured the inner lining of the arteries. The cholesterol deposits started to appear subsequently. He was very specific about this as follows. We cannot help regarding the process as one which has arisen out of irritation of the parts, stimulating them to new formative actions. So far, therefore, it comes on under our ideas of inflammation, or at least of those processes which are extremely nearly allied to inflammation. We can distinguish the stage of irritation preceding the fatty metamorphosis, comparable to the stage of swelling, cloudiness, and enlargement which we see in other inflamed parts. I therefore felt no hesitance in sliding with the old view in this matter and in admitting an inflammation of the inner arterial coat to be the starting point of the so-called atheromatous degeneration. Notice that he avoided claiming that inflammation causes atherosclerosis, since inflammation is a response to injury, not its cause. In addition, 2,000 years earlier, Celsus had defined inflammation as calor, dolor, rubor, and tumor, heat, pain, redness, and swelling, to which Virchow later added disturbance of function, functionalisa. All of these are signs and symptoms that could be seen or felt, but this type of inflammation is asymptomatic, and its presence can only be verified by microscopic examination showing cloudiness and swelling. It is now claimed that this type of inflammation can be detected by acute phase reactants such as high sensitivity CRP and interleukin-6, and some even assert that these have a causal role in atherosclerosis and coronary heart disease, rather than representing markers that merely have an association relationship.
Next question. Please tell us exactly what would be the most important issues when we read the results of blood tests, and where we have a huge table with all kinds of molecules and percentage. What should we focus on?
So, should we focus on LDL size, HDL, high sensitivity CRP, or some other measure of inflammation like interleukin-6? That's apt to be determined by the probability that a new drug will be profitable rather than its efficacy, which along with long-term safety can take years of studies to prove. We have already seen that lowering LDL bad cholesterol as much as possible has no value. Yet Repatha and Praluent, which lower LDL by a different mechanism, are now approved simply because they lower LDL in patients who do not respond to statins. The wholesale costs of both are presently over $14,000 a year. They must be given by injection along with the maximum dose that can be tolerated. Indicated previously, drugs that raised HDL, good cholesterol, backfired since they increased cardiac deaths, but others are in the pipeline and will likely be approved if no problems surface, since the ability to lower LDL or raise HDL has become a surrogate for coronary events and deaths.
But as an abstract, if there are any known bad influence of high LDL values in the blood, what drugs might be available to counteract these effects?
As noted above, small dense LDL particles increase risk for coronary events, but there are no medications, including statins, that specifically target these. There's no reason to suspect that lowering HSCRP or other measures of inflammation will be any better, since these are also merely risk markers. Nevertheless, Time magazine cover story claimed the HSCRP test measured, quote, the presence and the intensity of inflammation in the walls of the blood vessels. In contrast, cholesterol only measures how much fat is lodged in the vessels of the heart. An HSCRP test shows how likely it is that those plaques will burst. It is false claims like this that sell drugs, and as an old adage goes, never let the truth get in the way of a good story.
Please tell us some concluding quotes and comments.
Well, if reducing inflammation prevented coronary heart disease, then why was the powerful anti-inflammatory drug Vioxx recalled because of increased heart attacks, strokes, and sudden death? Perhaps there are other types of prophlogistic activities that should be called something else. As the Nobel laureate Richard Feynman emphasized, I learned a long time ago the difference between knowing something and knowing the name of something. And as Albert Einstein repeatedly warned, not everything that can be counted counts, and not everything that counts can be counted. The first part of this statement applies to LDL, HDL, CRP, interleukin-6, other markers of inflammation, which are easy to measure and may have little significance with respect to causing heart attacks or deaths. The second part is pertinent to our inability to measure something we call inflammation, but may represent a response to injury that has different causes, including homocysteine infections and stress. Coronary heart disease is a multifactorial disorder that has no vera causa, or true cause, without which it will not be present. This is in contrast to tuberculosis and poliomyelitis, which the tubercle bacillus and poliovirus must be present since they are their vera causa. As a result, vaccination can prevent these and other infectious diseases, but there is no vaccine to prevent coronary heart disease, even though various pathogens have been consistently cultured from atherosclerotic plaque. It's also important to emphasize that it's possible to have the above and other bacterial and viral infections without ever having any signs or symptoms to discuss their presence.
Dear Dr. Rosch, please tell us for our viewers what else could we discuss in a subsequent interview.
We will discuss what really causes heart disease in a subsequent interview that will also expand on how Big Pharma persecutes critics with opposing views and along with food manufacturers deceives the public with erroneous claims and doctoring data in company-sponsored studies. We'll also explain, as John Ioannidis claimed in a landmark article, why most published research findings are false. So stay tuned.
Dear Dr. Rosch, it was an amazing part 1 interview, and soon as you'll be ready, please let us meet for part 2 of our mini-series. But most importantly, please take care of your health. I'm a little bit worried regarding the recent surgery you had.
Yeah, no, so far nothing on the horizon, so I'm not looking forward to any other surgical procedures. Be anxious to see how this turns out.
Well, actually, we already have 2 parts in this first meeting, but would you have time for part 3 later this year?
Probably, but let's see how this goes first.
This is great. Let's meet soon for part 3 of our amazing mini-series.
Yeah, I agree.
Thank you very much for this amazing interview.
Okay, thank you.
Okay, bye-bye. Trebuie să precizez încă o dată faptul că sub nicio formă această emisiune nu poate fi considerată un înlocuitor al consultului medical de specialitate, iar opiniile prezentate aparțin exclusiv invitatului și nu sunt opiniile mele sau ale televiziunii române. Singura modalitate pentru a face posibilă exprimarea unor asemenea opinii a fost prin intermediul unui invitat de cea mai mare notorietate în domeniul medicinei, psihologiei, psihiatriei, biochimiei, neurologiei, a metabolismului și a altor domenii, fapt care i-a permis să elaboreze teorii interdisciplinare și să construiască ipoteze excepționale care au fost dovedite de numeroasele studii pe care domnia sa le citează. În finalul interviului, Dr. Rosch mi-a promis că va urma încă un interviu despre adevăratele cauze ale maladiilor cardiovasculare, persecutarea oamenilor de știință de către Big Pharma și despre producătorii de alimente care înșeală publicul cu pretenții eronate și date medicale false în studiile sponsorizate de companii și multe altele. Fiți alături de noi data viitoare la o nouă întâlnire cu emisiunea Știință și Cunoaștere.